Time, no?
Doctor,
3:30.
yeah, it's time. Dr. Chandni, I would request please stop the sharing so that we can start. And we are live now. With all your permission, we are starting the session.
Sure.
Okay, sir. Thank you. And to avoid any kind of audio issues, I am muting all of you. When you are talking, you can unmute from your end. A very good afternoon and a warm welcome to one and all present here. I am Debolina from Clearnet. We are very much proud to be a part of this journey as a digital partner. Clearnet is India's largest live digital CME and doctors generated medical content platform. So here is a short glimpse of Clearnet. Thank you so much all for your patience. You can always find us on Google www.clearnet.com. We have various services available. One is the live sessions, which has been conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors. Besides, we have telemed service, and you can play polls and quiz in your leisure time. So you all are invited to visit our site. So now, without further delay, I would like to hand over the session to Dr. Prasant Karia to start with the scientific program. Over to you, sir.
Thank you, Deblina and Clearnet, for being a partner of NNF Gujarat. Now, coming to the point, without taking much of a time, in Neonatal Pathshala, we have started with PG case presentations, PG case seminars, CME, and panel discussions. We also had a quiz competition, and now we are adding one more thing into the Neonatal Pathshala, and that is a journal club reading. So I invite our president, Dr. Sandeep Trivedi, to welcome one and all. Sandeep bhai. Sandeep bhai, you are mute.
Thank you, Prashant. Neonatal Pathshala is very useful to all the pediatrician who is work in the neonatology and also PG student also. We are very thankful to Dr. Ashish Mehta sir and Dr. Somsekhar sir, those who are advisor of the NNF, and Mohit sir also. And thank you very much. And I welcome Dr. Chandni and Dr. Ravi and Dr. Phagun as the expert. Thank you, Prashant.
Thank you so much. Today we are having a journal reading on acute kidney injuries, and the same will be presented by Dr. Chandni Dhanani. She is a neonatal fellow in Nirmal Hospital, Surat. She will be presenting the case, and we have today two experts. One is Dr. Ravi Parikh. He is from the Ahmedabad and he's a neonatologist from the Ahmedabad, and Dr. Phagun Shah, a nephrologist from Surat. So without taking much of a time, I invite Chandni to present the case. Yeah, Chandni. And by the time she is presenting, just for the information of all others who have joined through the Clearnet platform, that NNF Gujarat is hosting West Zone Neocon, that is from 26th August to 28th August at Udaipur. So all are requested to join us for the West Zone Neocon conference. Thank you. Chani, you can present the screen. Thank you.
Next week, we'll be having a presentation on Down syndrome on 8th. A reminder.
Yeah. So, sir, you can just share the details of next our Neonatal Pathshala. Somsekhar sir.
So we will have Dr. Anil H, a DM resident from our college, will be presenting a case on Down syndrome, and we will have two experts, one neonatologist, Professor and HOD, Dr. Chandrakala from St. John's, who will be the expert, and other one will be Dr. Ratna Puri, who is a geneticist from Gangaram Hospital, Delhi, who will be joining the session as expert. So I think it will be a very interesting discussion, including stuff like artificial intelligence and machine learning, etc. So it would be very exciting for people to join. Thank you.
I think Phagun sir had joined as well.
Yeah, Phagun sir has also joined. I request Chandni. I think she is having some issues. Mohit bhai?
Yeah, I have joined here.
Yeah.
No, maybe you people can share her slides if she cannot share the slides. She's joining. Dr. Prashant, can you share her slides if you have them?
Sir, I'm out. I've joined from a mobile app today.
Okay. Sorry.
I'll just interrupt
Sir,
how briefly how
I
we will take the session. I just wanted to inform that. So first, Dr. Chandni will be presenting the slide, and we will discuss clinically about the paper. Dr. Fagun Shah will be assisting and asking the questions during that time as well to Chandni. And at the end of the session, we'll discuss a little bit about how the journal club is presented with evidence and what type of paper is this, and that I will a little bit take about that as well. So that's how we'll go about for the session.
Dr. Ravi, I think Dr. Chandni is not in
हेलो
the
सर सर वो ग्रुप में है, उसके ना थोड़ा इशू आया लैपटॉप में, मैं अपने लैपटॉप पे उसको प्रेजेंट कर रहा हूँ।
ओके फाइन, ठीक है।
लेकिन अभी इसमें ना सब कुछ हो रहा है, मेरा ना वीडियो स्टार्ट नहीं हो रहा, लेकिन चलता है बिना वीडियो के। शी कैन शेयर द स्क्रीन एंड शी विल डू इट।
ओके फाइन, परफेक्ट, ठीक है, ऑलराइट।
तब तक आप डॉक्टर रवि आप कंटिन्यू करिए ना प्लीज, 2 मिनट में सेट हो जाएगा।
स्टार्ट बिफोर दैट गेट्स डन। डॉक्टर रवि, maybe you can take.
Yeah. So basically, it is a very warm step from the Gujarat NNF to introduce such type of journal club in the discussion as well, and it is very, very important session. Not only practically how you look at the evidence, what you learn from the journal, but also in your MRC fellowship exams and everything. One of the session either MCQs or even in short.
हेलो, हाँ उसका ना लैपटॉप में से ऑडियो सब खराब हो गया था, चल नहीं रहा था, तभी वो मेरे लैपटॉप से प्रेजेंट कर रही, बस 2 मिनट में शुरू हो जाएगा।
Okay, so not only in your practice how important it is, but also in your fellowship exams also, the one of the question will definitely there about the evidence of the paper and how do you read the paper and take from there. So that's how we are going to generate the session, and that's how the presentation flow will also be there. So you will learn definitely something new in this session, I hope. Dr. Somsekar, you want to add anything about journal club reading?
Yeah, so journal clubs generally are done on papers that are published recently, or maybe even very old papers, but which have been very significant for the change in the field. So when you do a journal club, what is expected from the participant is not only discuss the article in question, but the participants are also expected to read all the references and the relevant literature that is related to that particular article and come from the paper that is being presented, but also from literature that is relevant. And the most important part of the journal club is actually the methodology. So as to how the research was conducted and whether the methodology was right. So basically, you're going to be critiquing, not criticizing the paper in terms of whether the study was done appropriately, was it the right design, discuss that particular question. If the design was right, whether the sample size was appropriate, whether sample size, if the sample size and design was appropriate, conduct of the study done properly. Was there any methods to check for quality of the data collection, whether the data was collected properly, and then later on, how was the data analyzed? Was the data analysis presented, discussed before the study was started, or data analysis was done afterwards as a secondary afterthought? Because analysis that is done as an afterthought in a study is usually not going to be of very good quality. So those things should come out in the discussion. And when you talk about methodology, whether the right statistical steps were applied, whether those tests have been presented correctly. So not only the application of statistical tests, but whether the data has been appropriately presented. And then you go on to the discussion as to how was the study discussed. Did the discussion omit any significant papers? So that is the importance of reading other papers related to that paper in that area. So if somebody is discussing some particular study, say surfactant, and they have omitted references to very important papers published recently or previously, then that is a significant drawback of the paper. So basically what you're doing is a reviewer's job of a paper, but after the publication, finding out whether the article has been done properly. So doing a general club not only what it gives you, the skill set for doing a general club allows you to interpret data that has been published and then use the results accordingly. So it's hence knowing how to do a general club, and not only that, how to present a general club is also important for postgraduate residents and doctors. So this importance can be understood from the fact that when COVID came, a lot of papers were published and presented, and many of the papers were not of good quality, and a lot of people did treatments based on poor quality presentations. So I think that's something which we need to understand and realize that it's a very significant part of our learning. I can continue, but if people are ready, we can start the presentation.
Yeah. So, sir,
I think Ravi bhai, hello.
Mohit?
बोलिए फागुन भाई बोलिए please.
I think Ravi bhai, instead of giving the comments at the end of the paper, what we can do is that once the section is over, I mean, we can just, you can also come out with whatever points you need to suggest. As for example, like the study design methodology, what is the application of the analysis, etc. Because I will be a little bit more clinical as far as this paper is concerned. So I think instead of your comments coming down at the end, it would be better like if we go with the flow along with the presentation.
No,
if it's okay to you.
Dr. Fagun, what will be there is I want to show them the critical appraisal tool as well, and it is a tool available online. So stopping the screen of Chandni and then putting my screen will be a taxing. So that's fine. The paper is a multi-center trial, so I will appraise it later, but it will be better if we do it at the end.
Okay. So in that instance, what I will do is this, that I will try to be more clinical as far as this paper is concerned, and then you can just put your clinical appraisal at the end. You want it in that way? Okay.
Yeah, that can be done, because we did discuss this paper in our unit meeting of General Club. Dr. Fagun was there, and we were fortunate to have Dr. Sanjay Wazir, one of the authors of this paper. So that was the thing. So like when we do a critical appraisal, there are two things for our fellows. One is how you critically appraise the paper, how you do how the study was been done, and what are the critical appraisal, what are the critical points. But the other thing is we need to do is how it is useful in our practice. So that is what is also very important for us also. So those points needs to be discussed and should be taken as a take home point. So in that, Dr. Fagun Shah can very well give his inputs, and then at the end, Ravi sir, you can just critically appraise how do you do. Ideally, you should do it, and what has been done in this paper. In between, if you feel any point, you can ask. But she will be presenting as if a normal new fellow does that, because that is how practically it is being done. So this is how.
Yeah, that will be perfect. Like we'll just introduce the steps how to critically appraise the paper and take it from this paper as well. But that will be like a discussion rather than I will be asking Chan. So nothing to worry about.
Sure.
Okay. So we can start.
Yeah. Are you able to see the screen?
No. Yes, now.
Okay. It's okay, maximized?
Yeah.
Okay. Tell me.
Good afternoon, sir. Hello.
Yes, you are audible. You can go ahead.
Good afternoon.
Good afternoon.
Myself Chandni Danani, a neonatal fellow at Nirmal Hospital, today under the guidance of Dr. Mohit sir, will be discussing on risk factors and outcome of neonates with acute kidney injury needing peritoneal dialysis, the results from prospective TINKER, the Indian PCRRT Iconic Neonatal Kidney Educational Registry Study. Introduction. Despite persistent improvement in the care of critically ill neonates, acute kidney injury, AKI, is a commonly faced condition in infants admitted to neonatal intensive care units, which has increased risk of mortality and morbidity. Neonatal AKI has a variable incidence rate between 18% and 70% across various studies. Besides prematurity, infants with AKI are more likely to be outborn, have risk factors like hypoxic ischemic encephalopathy, sepsis, seizures, congenital heart disease, necrotizing enterocolitis, and they need surgical evaluation. The first line treatment for AKI includes conservative measures. Kidney replacement therapy may be required when these interventions fail. Mortality rates in neonates with severe AKI are higher, which may vary from 10% to even 76.9%, depending on the underlying etiologies, severity of AKI, and comorbidities. So this thinker, the Indian PCRRT iconic neonatal kidney educational registry study, analyzed risk factors and outcome of neonates with acute kidney injury needing peritoneal dialysis from level 2, level 3 NICUs in 11 centers across India. Difference between hemodialysis and peritoneal dialysis. Hemodialysis, it needs vascular access, it needs anticoagulation, costly, needs an expertise, more effective, but the challenges with blood-based kidney replacement therapy is relatively small body size of neonates. Whereas in peritoneal dialysis, there is no need of vascular access, no need of anticoagulation, less cost effective, easier to use from technical standpoint by hospital staff, low pro-inflammatory effects, practically and technically feasible in premature infants also. So the objectives are, primary objective is to analyze the risk factors which are associated with neonatal AKI who needed acute peritoneal dialysis from Tinker studies. The secondary objectives are to analyze outcomes, that is hospital stay and mortality of the neonates with AKI who needed acute peritoneal dialysis from Tinker cohort. To analyze whether severe AKI needing peritoneal dialysis is the worst prognostic factor in critically ill neonates. Materials and methods. Study design. It was a multi-center national prospective cohort study at level 2 and level 3 NICUs in 11 centers across India. Neonates were enrolled consecutively from August 2018 to August 2021 for 3 years duration. Ethical approval was obtained from all the participating centers. Inclusion criteria. Neonates less than 28 days who were admitted in the NICU and those who received intravenous fluids for at least 48 hours for hydration or nutrition. Exclusion criteria. Death within 48 hours of admission, presence of any lethal chromosomal anomalies such as trisomy 13, 18, and encephaly. Requirement of congenital heart surgery within first 7 days of life, and neonates receiving routine care in nursery. Complete protocol. The complete protocol was followed as per mentioned in the study publication. Data were collected in the Tinker study by researchers assessing all the neonates admitted to the level 2, level 3 NICUs using a paper-based questionnaire or an electronic medical record database. Data entry was conducted by each of the participating centers using a web-based database or a form online case report. Demographics data like maternal age, gravida, parity, chronic and pregnancy associated conditions, medications, history regarding peripartum infections, history regarding drug intake during the pregnancy. Neonatal variables like gestational age, birth weight, mode and site of delivery, reasons for admission, initial temperature, and resuscitation data were taken into consideration. These are physiological and laboratory parameters of neonates, which were documented daily for 1 week after the NICU admission, and thereafter, first day of week till discharge or 120 days of admission or either transfer or death. The physiological data were weight, blood pressure, fluid intake, total fluid output, evidence of fluid overload, more than 10% weight gain within 12 hours of NICU stay, use of nephrotoxic drugs, and urine output. Laboratory parameters were blood creatinine, urea, sodium, potassium. Markers of sepsis include blood culture, urine cultures, and other cultures were recorded within 12 hours of NICU. Results. Among 1,600 patients, 491 neonates were diagnosed with AKI. Stage 1 included 168 patients, stage 2 included 93 patients, stage 3 included 230. Among 230 patients, 44 patients required peritoneal dialysis from stage 3. The indications for acute peritoneal dialysis In 21 patients, it was fluid overload, oliguria, and metabolic acidosis. In 11 patients, fluid overload and oliguria. In 12 patients, fluid overload, oliguria, metabolic acidosis, and hyperkalemia. So screening from level 2, level 3 NICUs among 11 centers, total 2,839 patients were screened. Among that, 1,680 patients were enrolled. The patients who were receiving neonates who were receiving routine care, or the patients who died within 48 hours, or who did not receive any IV fluid within 48 hours of admission, were excluded. So total 1,680 patients were enrolled. Out of this, 80 patients were excluded because they were having lethal chromosomal anomalies, and a few of them had congenital heart surgery within first 7 days of life. So the final list of patients included 1,600 patients. Out of that, 491 patients had acute kidney injury. And after 491 patients, 44 patients required acute peritoneal dialysis. The risk factors that are associated with AKI requiring acute peritoneal dialysis were divided into two variables: categorical variables and continuous variables. Categorical variables had in frequencies and percentages using chi-square or Fisher's exit test. Continuous variables in medians and interquartile range. The interquartile range ranged from 25th to 75th percentiles using Wilcoxon-Rank-Sum test type of unpaired t-test. The main outcome was to identify the variables influencing the requirement of peritoneal dialysis among neonates with AKI. These are categorical variables. The variables included severe peripartum event, resuscitation in the delivery room, respiratory support in the NICU, significant cardiac disease, necrotizing enterocolitis, interventricular hemorrhage, evidence of fluid overload within 12 hours of NICU stay, and requiring inotropic support. The patients with AKI in which peritoneal dialysis was required, that is total 44 patients. Out of 44 patients, 4 had the history of severe peripartum event, 26 required resuscitation in the delivery room, 42 required respiratory support in the NICU, 34 had significant cardiac disease, 4 had necrotizing enterocolitis, 9 had interventricular hemorrhage, 5 of them had evidence of fluid overload within 12 hours of NICU stay, and 38 of the babies required inotropic support. While patient AKI without peritoneal dialysis were 447 patients, 10 of them had history of severe peripartum event. 155 babies required resuscitation in the delivery room. 373 required respiratory support in the NICU. 182 had significant cardiac disease. 11 of them had necrotizing enterocolitis. 29 had interventricular hemorrhage. 15 babies had evidence of fluid overload in 12 hours of an NICU stay, and 255 required inotropic support. Among the neonates, the patient requiring peritoneal dialysis, the mortality was higher in the patients requiring peritoneal dialysis, and there was significant cardiac disease, which includes history of HSPDA, PPHN, cardiogenic shock, and other congenital heart disease. So this was a prospective multi-center study. The data were collected by Tinker database. All the patients less than 28 days admitted in level 2 and level 3 NICUs were included, who required 48 hours IV fluids for 48 hours and had an evidence of acute kidney injury as per KidGo criteria. AKI with neonates with PD versus those without PD. The evidence, there was evidence that the patients with AKI with peritoneal dialysis, the hospital stay was lower compared to those without peritoneal dialysis, and the mortality was higher in those patients requiring peritoneal dialysis. Continuous variables. Continuous variables were urine output, serum urea, serum create, hemoglobin, and serum pH. Patients with AKI requiring peritoneal dialysis, the urine output was which was ranging from 0.7 to 1.5 ml per kg per hour. Serum urea range from 35.1 to 75. Serum create range from 1.25 to 2.43. Hemoglobin was 13 to 16.5 gram per liter, and pH range from 7.02 to 7.29. While patients with AKI without peritoneal dialysis, the urine output ranged from 1.1 to 1.6 ml per kg per hour. Serum urea was 28.9 to 53.9. Serum create was 1 to 1.5. Hemoglobin was 15.1 to 18.2, and serum pH was from 7.2 to 7.32. Multivariable logistic regression technique was used to determine the relationship between independent variables and PD requirement. Higher odds of requiring PD described all the categorical data. Lower odds for needing PD were higher HB and higher Apgar score at 5 minutes. Lower median requiring peritoneal dialysis was Apgar score, urine output, hemoglobin, and serum pH. Higher median requiring PD was serum creatinine and blood urea. Comparison between the hospital stay and mortality rate. Babies requiring peritoneal dialysis, the hospital stay median duration was 7 days, which ranged from 4 to 14 days, while those babies who did not require peritoneal dialysis was 11 days, ranged from 6 to 21 days. Hospital stay after excluding dead neonates were 14.5 in babies requiring peritoneal dialysis, and the range was from 8 to 41.8 days. While in babies not requiring peritoneal dialysis, the hospital stay after excluding dead neonate was 12 days, range from 7 to 21 days. Mortality was high, that is 70.5% in babies requiring peritoneal dialysis, and it was 7.6% in babies who did not require peritoneal dialysis. Discussion. The overall incidence of AKI within the clinical study population was 30.
Yeah, Chandni.
Yes,
Yeah, now before proceeding with the discussion, can we take up some clinical important parameters which we need to discuss over here in this study?
yes, sir.
Yeah, so can we go a little bit back on the indications of peritoneal dialysis? No, go ahead. Go ahead. Yeah. Just go back. Just go back one slide. Yeah. So here they have mentioned. No. Go ahead for the laboratory slide. The laboratory parameters. Yeah. No. Go back one slide. Yeah, this slide. Yeah, laboratory parameters. So here the measurement of laboratory parameters included blood, creatinine, urea, sodium, potassium, and markers of sepsis. So as far as electrolytes and creatinine and urea monitoring were concerned, they were recorded within the first 12 hours of the NICU admission probably. And then how frequently were the laboratory parameters repeated? That is number one. And number two, definitely they must have recorded the urine output, because basically fluid overload was an important parameter as far as the indication of PD was concerned. So how frequently was the urine output monitored? I mean, it was a hourly monitoring, or it was a monitoring once in 24 hours?
Sir, urine output was monitored every 12 hours. And sir, lab parameters were done every daily for first week, and thereafter first day of week till the babies were discharged, or till 120 days of admission.
Hello.
Hello.
Yeah, now you're audible.
Sir, lab parameters were done daily for first week of admission, and thereafter every first day of week was done till the babies were discharged, or till 120 days of admission.
Okay. So all these parameters were done at least once a day for the first week of admission. Okay.
Yes,
and as far as the urine output is concerned, how frequently the urine output was measured? Was it measured hourly, or was it measured 6 hourly, or was it measured 24 hourly?
Sir, it was measured twice a day, sir, along with evidence of fluid overload, sir.
Okay. And the fluid overload was what? The fluid overload parameter was more than 10% or more than 5%?
More than 10% weight gain.
Okay. Within 12 hours of an acute. The reason I'm telling is that more than 10% is basically a very high risk factor for a mortality, because if you take into consideration the fluid overload, if you go on to the next slide. Just go next slide. Yeah. So indications of PD as far as concerned, you can see that fluid overload and oliguria are the important parameters where the PD was indicated. And in fact, most of the times what we do is this, that we take into consideration these two parameters before initiating PT. Though there are also other indications for the peritoneal dialysis like severe hypo or hypernatremia, hyperkalemia, severe acidosis, etc. But most of the times what we do is this, that we take into consideration severe oligoanuria or fluid overload. And these are the two important parameters. So if we take into consideration the fluid overload, if the fluid overload exceeds 5%, so if it goes above 5%, then in just increase in 1% of the fluid overload beyond that will increase the risk of mortality by 6% every time. And this is an independent variable. So waiting for basically the fluid overload to go beyond 10% will definitely increase the mortality. And probably this might be one of the reason, I can't say, but this could be one of the reason why the mortality in the patients who are undergoing PD is very high in this study. That is number one, which I would like to comment over here. Number two, you can just go ahead. Yes, go ahead. Go ahead. So if you take into consideration this category, no, go back. If we, yeah, the categorical data, if we take into consideration here, I see two important parameters over here. That is a significant cardiac disease and inotropes, where the p-value is less than 0.001. So these are the two important parameters which have an influence as far as the indication of PD in a patient with AKI is concerned. If we take into consideration these inotropes, have they mentioned that how many inotropes they have been using, one or more than one?
Sir, more than one in many patients.
More than one in many patients, but they haven't differentiated as of that how many patients with one inotrope required PD or two inotropes required PD or three inotropes required PD.
Okay.
Okay, but from this it is very, very clear that in the patients who are having cardiac disease, probably there is an hypoxic content, which is also very, very important. And in the patient who are having shock, especially if the need of the inotropes are there, here also there is a significant amount of ischemic damage to the kidneys. So hypoxia and ischemia, two are very important variables which might be responsible for the AKI, and superimposed on that, you have other parameters as well. Like for example, patients with sepsis and NEC, patients requiring delivery in the resuscitation room, and especially they have not taken into consideration, I think, the use of the nephrotoxic drugs, whether they have taken or not, the importance.
They have taken.
Can you go one slide ahead? No, there is no mention regarding, I think, the use of the nephrotoxic drugs. This is just from the data that about 25% of the drugs that we use in our NICUs and PICUs are nephrotoxic. And if you take into consideration the amount of the prescription, then 40% of the prescriptions in the ICUs are of the nephrotoxic medication. So this is again a very, very important factor which also needs to be taken into consideration over here, because we commonly use amikacin, that is all aminoglycoside, vancomycin, acyclovir, amphotericin B, IVIGs, etc. These are the very common drugs which are used in the NICUs and PICUs. So these drugs are highly nephrotoxic drugs from the virtue of that they might lead to significant fluid overload, sucrose overload. They can lead to direct tubular damage, direct epithelial damage, direct oxidative damage to the tubules and also epithelial cells, etc. So all these factors are very, very important. And these are the variables which might not be direct having an influence on the renal damage, but this might multiply the chances of having a renal damage, and per se again after that might have an important influence or, as far as the mortality is concerned. Okay, you can go ahead. What is the just go one slide back. Mortality was 70% in the patients requiring PD.
Yes, sir.
Yeah. So I think here also, if we compare, have you compared the study to the Awaken study? Because this study was designed on the basis of the Awaken study. Because I think the mortality there in the patients with PD was around 30%. I don't remember that. Do you have it? What was the mortality in the patients requiring PD in that study?
So it was around 30%.
30%, yeah. So here you can see the mortality rate was very, very high, 70%. So every 7 children out of 10 children who required PD had mortality. So why was this the reason? So have they mentioned or have they, what we say, discussed regarding the higher mortality rate as compared to the Awaken study over here? Because I think the percentage of the children requiring the PD was also very high. I think here it is around 9%.
Yes, sir.
Yeah, and the patients requiring PD in Awaken study was around just 4%. So why was so much of discrepancy as far as the PD's requirement is concerned? Is it because we are allowing a lot of fluid overload in our patients in the NICUs and not taking care of the urine output, or we are giving inadvertent fluids, not taking care about the urine output, or not monitoring the urine output? Because urine output monitoring is a very, very important factor, especially high-risk neonates who are level 3 neonates, patients with extreme low birth weight neonates, and all the patients who are having what we say significant cardiac disease, adverse postpartum events, patients on inotropes, patient on ventilatory support, patient with sepsis and shock with inotropes, 1 or 2 inotropes. All these are potential patients who might develop AKI or who are already in having an acute kidney injury. So these patients require very stringent monitoring of the urine output, and that's why I'm asking you that why the what we say the fluid, the urine output monitoring was. How was the urine output monitoring done? Whether the monitoring was done once in 24 hours, because for neonates, if we wait for 24 hours, there will be significant amount of fluid overload. We need to monitor the urine output and the input, that is the input outputs are very, very frequently, so that we can detect the urine the fluid overload quite earlier, and we can modify our fluids so as to prevent the child going into significant amount of fluid overload and then requiring RRT. Because anyways, when you institute RRT, the risk of mortality is definitely going to be a little bit higher as compared to those patients who are not requiring RRT. Okay. You can go ahead. Next slide. Okay, so serum creatine values and hemoglobin. So here again, the important factor point is hemoglobin. So you can see here that the hemoglobin again is a very important continuous variable, which is important, and it is very, very important that we try to maintain the hemoglobin about what was the range of hemoglobin, which was AKI with PD 14.5 and 16.4. Okay, so anyways, but the hemoglobin again is a very important parameter. We were not stressing upon this. Probably maintaining a good hemoglobin or a good hematocrit is very, very important from the point of view of the oxygen carrying capacity of the blood and the proper oxygen of the kidneys. This might be one of the reasons why hemoglobin has been important continuous variable. You can go ahead, next slide. Yeah, I think I will leave this slide for Ravi Bhai to discuss. You can go ahead. Next. Yeah, I think this is probably the hospital stay was taken into consideration, including the dead neonates. So in fact, the patients who are on PD, probably the 70% mortality was there. So I think that variable was taken into consideration later on. So this patients with PD with a less hospital stay was actually negated. Okay, go ahead.
Discussion.
Yeah, you can go ahead. Yeah.
The overall incidence of AKI within the Tinker study population was 30.7%. Out of which 9% required peritoneal dialysis support. Neonates who needed peritoneal dialysis had a history of maternal severe peripartum events, resuscitation requirement in the delivery room, respiratory support in NICU, sepsis, significant cardiac disease, intraventricular hemorrhage, necrotizing enterocolitis, fluid overload, or the use of inotropic drugs. Neonates with AKI with peritoneal dialysis versus without peritoneal dialysis were found to have significantly lower Apgar scores, less urine output, and lower serum pH. This suggests that we should avoid further fluid overload, avoiding nephrotoxic drugs, and intense daily monitoring of the kidney function in whom these risk factors present prior to development of AKI. The discrepancy, shorter duration of hospital stay and high mortality in AKI requiring peritoneal dialysis was likely attributable to the initial poor clinical condition, severity of illness, which includes sepsis and multi-organ dysfunction syndrome, rather than acute peritoneal dialysis procedure or related complication, as none of the neonates died during or just after initiation of peritoneal dialysis. The duration of stay in NICU influenced by mortality, so on further analysis, excluding neonates who died, the median duration of stay not differ significantly between the two groups, the groups requiring peritoneal dialysis and the groups requiring who did not require peritoneal dialysis. The mortality rate exceeds 95% if AKI and multi-organ dysfunctions occurred together. Conclusion. Neonates with AKI with peritoneal dialysis versus without peritoneal dialysis was significantly associated with low Apgar scores, lesser urine output, lower serum pH, and history of maternal severe peripartum event, resuscitation requirement in the delivery room, respiratory support in an ICU, sepsis, significant cardiac disease, intraventricular hemorrhage, necrotizing enterocolitis, fluid overload, or the use of inotropic drugs. High mortality in AKI required peritoneal dialysis was likely attributable to the initial poor clinical condition, sepsis, multi-organ dysfunction syndrome, rather than acute peritoneal dialysis related complications. Limitations of the study: being a multi-center study, it was not possible to have a central laboratory doing serum creatinine for all the neonates. The treatment for sepsis and indications and the acute prescriptions were decided by the treating neonatologist. Summary. The study further reinforces the need to create awareness and identify the sick neonates early with the risk factors so that we should avoid further fluid overload, avoiding nephrotoxic drugs, and intense daily monitoring of the kidney functions prior to development of AKI. There is a need to keep a vigilant watch in the neonates with risk factors for development of AKI and need for peritoneal dialysis.
Yeah, Janani, the center to the whole question was that how did they define AKI?
So on the basis of KIDGO classification, stage 1, stage 2, stage 3, they were diagnosed. In KIDGO classification, urine output and serum creatinine, 2 parameters are taken into consideration. If the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, it is in the stage 1. If the urine output is less than 0.5 ml per kg per hour for more than 12 hours, then it is stage 2. And if less than 0.3 ml per kg per hour or anuria for more than 12 hours, then it is considered stage 3. And on the basis of serum creatinine, if the rise in serum creatinine is 1.5 to 1.9 times from the baseline in first 7 days, or rise is more than 0.3 mg per dl in first 48 hours, it is considered stage 1. In stage 2, if the rise in serum creatinine is between 2 times to 2.9 times from the baseline, it is stage 2. And if the rise in serum creatinine is more than 3 times from the baseline, or if the patient is already on peritoneal dialysis or hemodialysis, or acute rise more than 2.5 mg per dl in creatinine, was considered stage 3.
Yeah, but even the KDIGO guidelines, though it is now universally associated, this is basically the neonatal KDIGO, which is now universally accepted actually in all the studies to define the acute kidney injury. But even it has its own caveats, because if you take into consideration the neonates, especially your preterm neonates and also your full-term neonates, the first 48 to 72 hours might reflect the maternal creatinine. That is number one. Number two is number two is this, especially in your preterm neonates, the creatinine might start rising after second, third day of life. That is after 40 to 72 hours, might remain static for 5 to 7 days and then start declining. And this is probably because of the tubular dysfunction leading to the reabsorption of the creatinine. So these factors has to be taken into consideration. And that's why I say the urine output monitoring is a very important single criteria, which also has to be reinforced equally, because if you take into consideration the Awaken study, in fact, they have mentioned that if the urine output criteria would have been removed, they would have not identified 30% of the patients. Okay, because the urine output is single important thing, which is quite objective, which is you can visualize it and you can also monitor it very stringently by either putting a catheter or you can do a diaper bed, etc. And I think the monitoring should be more frequent and stringent so that you can pick up the patients within first 4 to 6 hours. Because as I told you, that as the fluid overload increases beyond 5%, the chances of the mortality will increase. The odds ratio will increase towards mortality by 6% every time with the increase of 1% of the fluid overload. So it is not advisable to wait till the fluid overload goes up to 10%. If the child is having a severe oligoanuria, the urine output is less than 0.5 ml per kg per hour, and if your, say for example, if your urine output is going beyond, your fluid overload is going beyond 5%, that becomes an important criteria when you should intervene either by RRT or by what we say your conservative measures like decreasing urine output. Yeah, by decreasing your fluid intake, by limited use of the nephrotoxic medications, and all other things will come into play over here. So these are the two important things. I think the fluid overload portion has to be taken into consideration very, very stringently. So I think all other points are quite what we say have been taken into consideration. And I think in the adult children, we have this nowadays introduced is a renal angina index, which takes into consideration two things. One is the risk criteria, that is a high risk, moderate risk, or low risk. So all the persons who are admitted to the ICUs are considered as low risk. They are given the score as 1. Then the children who are admitted, who have undergone a bone marrow transplant or a solid organ transplant, they are given the point number 3 points.
3 points.
And the children who are and the children who are on inotropic support, 1 or more inotropic support and plus mechanical ventilation, they are given 5 points. And this has to be multiplied with your fluid overload. That is, if the fluid overload is less than 5%, it is, I think, 0. 5 to 10%, it is, more than 5%, but less than 10% is 2, or 5, I think 5 to 7, 7 to 10, and more than 10. So 2, 4, and 8, 2, 4, and 6, and then you need to multiply it. And if the score goes beyond 8, the risk of developing fluid overload and chance of getting an AKI is high. And if it goes, I think the maximum about 40 or something, it increases the risk of mortality in these patients. So we should have some sort of such index, which can be also what we say could be used for our this thing neonates, so that we can pick up these patients quite earlier, and we can institute the therapies, whatever conservative or RRT, quite earlier. Okay, and by the virtue of also, as far as this choice of renal replacement therapy is concerned, if you take into consideration the Awaken study, I think there were around 8-9 patients who had undergone PD. Otherwise, majority of them were on CRRT. Sorry.
Yes, sir.
Yeah, so majority of them were on CRRT, but because of the resource limited things which we have, and we have to function in a low financial setups, I think PD is one of the most important what we say tools to what we say to have a good biological and a biochemical milieu. We can maintain a good hemostasis as far as the acids, electrolytes are concerned. We can prevent the fluid overload, and I think it should be very handy, and the unit should practice, and the neonatologists should practice it on their own. Especially, they should not wait for the nephrologist to come down. They can do it on their own. It's a very simple procedure requiring very less technical expertise.
Do we know in Awaken study their fluid overload percentage was the same, more than 10% or more than 5%? Because the mortality is quite different in both of the studies.
Yes, absolutely.
Sir, I don't remember the percentage.
Okay.
So fluid the overload percentage is almost same. Almost. The only main difference which Dr. Fagun can also say about the comment upon that they had a lot of hemodialysis. We didn't have much of hemodialysis. Yeah. So that is one of the major interventional change, which is difference between this study and that study. Awaken.
Absolutely. Yeah.
Okay.
So that also can,
CRRT is basically a more controlled procedure in which the fluid removal is very gradual. You can maintain a good hemostatic value milieu in the body. PD is technically becoming a little bit difficult as far as not the insertion and not the procedure itself, but basically the problems with the mechanical obstruction, the problems with the small cavity, the problems with the child having neck and other things, the problems with the fluid overload causing much of what we say tension in the thorax, and lot of what we say subcutaneous edema, leading problems with the expansion of the chest, and sometimes it becomes technically very difficult to instill the fluid and have a good exchange in this patient. So that's why I'm telling you that the most important thing here is the right timing of the initiation of the renal replacement therapy, because most of the times we wait for the fluid overload to go beyond 10%, and which is quite higher, even if we take into consideration a small kid. So institution of the renal replacement therapy, apart from the apart from the biochemical factors, the other factors which has to be taken, or which has to be the main factors, includes the fluid overload status and the urine output status. So you don't wait for the fluid overload to go beyond 10%. As I said, as soon as the fluid, your percentage of the weight gain goes beyond 5%, in that instance, and if the child is having a significant oligoanuria, if the urine output is decreasing below 1 ml per kg per hour, because even in the awaken study, though the KDIGO has defined it the threshold as 0.5, but even they considered the threshold as 1 ml per kg per hour. So as the fluid, your urine output goes below 1 ml per kg per hour, I think that's the right time that we should start intervening.
Okay. Chandni, can you stop your slide sharing, please?
Yes, sir.
So now we will discuss about how this paper was with the evidence and what ideally we should whatever we discuss with Fagun sir as well. A little bit more will critically appraise the paper. Yeah, I think Mohit sir can also help in when I ask the questions with Chandni as well, and Fagun sir can peep in as well. Okay.
Sure.
So Chandni, what do you understand by the level of evidence? Which is the best evidence when you look into the paper, and where does this study fits into into the local of evidence, level of evidence?
Sir, it is a cohort study, prospective study.
Okay. So yes, so which is the best level of evidence? If you can look at the level of evidence from this triangle, what is the best and what is the least?
So best is systemic reviews, and the list is expert opinion.
Okay, so what is systemic reviews?
Sir, in this, on the basis of previous research data, what we have in multiple studies, we analyze all the data and then come to final conclusions in systemic reviews.
Okay, and mostly they are randomized control trial. The good, yeah.
Yes,
So the collection of good randomized control trials, when we put it together and do the systemic reviews, that is the best. Can you give any example of that?
Point trial.
Mohit sir?
Yes. Yes. Hi. Yeah.
Any good study you remember?
Yeah, there are a lot of like point trial is there, sport trial is there, and then we have other studies like but these are the two very commonly followed studies.
Yeah, perfect. And if we Chandni, if we want to look at a ready-made systemic reviews, then which website you will go on to, or which site you will prefer? Chandni?
Sir, no idea, sir.
Like if you Google in like if you Google anything what you want, any information, then is it okay? So whenever you Google it, they don't come out with systemic reviews. So we need the example of the best site is a Cochrane. Cochrane generally come out with only, yes, Cochrane review is the site where if you want to look at the clinical question. For example, if I want to look at whether indomethacin or paracetamol or whatever is, if I just Google it, if I put it into the Cochrane, then it will give me some systemic reviews if they are available. Okay, if there are no available, that means in that thing the systemic reviews are not done. So that is the best evidence of any practice, that we look into the Cochrane or we look at the systemic reviews. Then the randomized control trial comes. Yeah.
Yes, sir.
Meta-analysis, randomized control trial comes, and then the cohort studies. Now, why in this? Yeah, so this was you tell me that this is a cohort study. Yeah.
Yes, sir.
Yeah. So, but it is a multi-center cohort study.
Yes, sir.
And there are, see, it is still a very good study. Why this cannot be systemic review or RCT, and why it is a cohort study? Because the question we have asked, it cannot go into the system. It cannot go into the randomized control trial.
Yes, sir.
For example, if we want to look at the evidence body cooling HI, randomized to cool the babies with HI and not cool the babies with HI, and then you can randomize that and then take the result. But the question which this paper asked was, what are the risk factors and what is the incidence? Those things you cannot randomize. So it is actually, although it is a cohort study, this was a multi-center study and it is a quite a good study. Okay, so we can take home some messages from this study and apply into the local population. I will come to that next. So, and then there is a single case studies like what Dr. Somsekar told in COVID situation. Lot of papers were coming that tocilizumab was important, and those single case reports, they don't matter at all when we look into our clinical evidence. And the last one is the expert opinion. Okay, 15 years ago I was doing this, so we do this, or today I do this. But that's how we should learn as a neonatologist or pediatrician about how to think of the paper, and how we, even when we search, we should not Google it. We need to know which is the best evidence and good papers. Like when we look into Cochrane, when we look at the Lancet, NEJM, they will never publish any bad papers or any. They are all filtered papers. So that's what the importance of a good paper is. Clear?
Yes, sir.
Okay. Yeah. And now have like, do you, when, for example, this was a cohort study, and when you were preparing the slide, did you find any tools for appraising it? Like there are a lot of tools are available inside. So I'll just show you one of the
इंटरएटियल सेप्टम थोड़ा ऊपर की तरफ स्वीप कर, थोड़ा नहीं, थोड़ा नीचे.
Mohit bhai, please mute.
Oh, sorry.
So this is a very, very important thing. If you like, for all the participants, there is if you Google as a CASP study, CASP study, it is called CASP, Critical Appraisal Skill Program. These are easily available on the internet, and then you choose the study. For example, if this paper was a cohort study, multi-center cohort study, so I took the CASP program of the cohort study. So if you look at this checklist, CASP checklist, 12 questions to help you make a sense of cohort study. So when we read this paper, we need to get all these questions together. That what is the importance. So Chandni, I will just go through these questions, and the slide which you have prepared, just one or two things you can put in each of the question for me. Okay, are you here, Chandni? Question is, are the results of study valid? Yeah, they were definitely valid. But okay, so what are the results? We all know the results. We discussed with Dr. Fagun sir all the papers, and then only when the section A and B are right, there might be many papers which are not related, which are not good results. Then will the results have help locally? Then only we can see whether we can extrapolate this material and change our practice. So if section A and B are good, then only we jump to section C. So that's what these 12 questions will be there. Okay, and these questions will be in all the importance criteria. So the first question would be, when you appraise the paper, are the results of study valid? So did the study address a clear focused issue? Chandni, what was a clear focused issue? What they wanted to look at? Chandni, are you here?
Sir, am I audible?
Dr. Fagun sir is... No, now you are audible. Yes. So
yeah, now you are audible.
You feel that this study address a clear focused issue? Yes.
Yes, so the risk factors and its association with requirement of peritoneal dialysis in babies with AKI.
So yeah, so if you look at the right side, look at the hint. A question can be focused in terms of population studied. So population was similar in all the 11 centers, okay? Less than 28 days neonates, and the risk factor studied was also similar, okay?
Yes,
And is it clear whether study tried to detect a beneficial and harmful effect and the outcomes considered? So it was quite a clearly focused issue study. So that's a tick yes in this box, okay?
Yes, sir.
Second, was the cohort recruited in a acceptable way?
Yes, sir.
Now yes, majority of them they had a single, I think they had a single website from where they took all the details on all the 11 centers. My only little bit issue in this was that their management was different, so they didn't had a common protocol of diagnosing AKI, treating AKI and things, which that can be improved. Yeah, because they give the permission for all the centers to manage neonates as per on, but little bit this study can be improved, whether they can generalize the single protocol that this is exactly how AKI should be diagnosed and this is when the treatment should be done.
Sir,
What do you say, Fagun sir?
Sir, I think here the diagnosis wasn't an issue because the AKI definition was quite clear. They had used the KDIGO guidelines for defining the AKI over here. The main issue here was the laboratory parameters because they were measured at all the different 11 centers. And again, this different 11 centers might have a different value. Say, for example, if I am using a Jeff's method or a modified Jeff's method for the for serum creatinine, I'm using, if then in that instance, I might have a very what we say perfect serum creatinine value. Say, for example, if I cut down, normally the reference range may be around 0.2 to 0.4 in the neonates from preterm, if you take into consideration to the full term neonates, etc. But if a simple Jeff's method or a simple method is used for the diagnosing the serum creatinine values, for putting up the serum creatinine values, then I might have a value of as high as 0.8, which might lead to a false inclusion of the child of that neonate into a AKI, this thing, and in that instance, this AKI, which is actually not an AKI, which might not be actually an AKI, which have been considered, and it had been considered as what we say a AKI which was not having any sort of side effects. So in short, I think the problematic point here was the laboratory parameters which were not uniformly measured because they were measured across 11 centers. But as far as the diagnosis is concerned, even the AWACN criteria, they took into consideration the KDIGO guidelines. And nowadays, all the centers where the AKI is defined, not only for the pediatric population and the neonate population, but also for the adult population, the KDIGO guidelines is normally most of the times used as a criteria for the definition of the AKI.
Okay, so majority of the study was fine. So if we want to do another study, then this what you told about the laboratory parameters, we can formalize and make it same to all the centers. Yeah. Okay, so that was the cohort recruited in acceptable way? Yes. There was everybody included? Yes, that was fine. There was no question at all about that. So only when these two questions are right, then it is worth continuing reading the paper, and we were happy with the thing. Okay, was the exposure accurately measured to minimize the bias? So just look at the hint on the right side. And then can we?
Yes, sir.
Yeah, so I also feel all of them, the measurements truly reflect what you wanted them to have. So the chart you showed, the flow chart and everything was quite okay. And as Dr. Fagun, so where all the subject classified into exposure using the same procedure, that was fine. So same thing was said. So that is, I'm happy with this assessment. So was the outcome accurately measured to minimize the bias? So measurements were similar in groups. The subjects were blinded to the exposure. Does this matter? Because this was a risk factor study. So this may not be, if we are comparing different groups, then only that randomized and biased things comes. But this study was not about comparing anything. It was so still I am happy with this answer as well. Yeah. Then comes how the authors identified all important confounding factors. Yeah, they had excluded so confounding factors, and they have excluded like first 48 hours death or anybody. This was also a very good thing in this paper as well. And have they accounted or have they taken account of the confounding factors in design and analysis? It was done. Okay, so that is also right. And was the follow-up of subjects complete enough? Did they follow all the babies?
Yes, sir. Till
Yes,
120.
they had
120 days.
Yeah. So that is quite. And was the follow-up of the subjects long enough in this study? That's quite an enough time. 120 days. Like if we are looking at the neurological outcome or something, then we need quite a prolonged study. But otherwise, I think the follow-up was also quite okay. And what are the results? What are the results of this study that we discussed? All that the patients with undergoing cardiac treatment or inotropes, they had a high chance of peritoneal dialysis. So that is fine. And how precise are the results? They took the confidence intervals as well in this, and so that was also good. Do you believe in the results, Channi?
Yes, sir.
Okay, so that's what Dr. Fagun also told. Apart from little bit high mortality in each subjects, it might be due to the sick of the patients you are getting from the periphery. Because if you see the studies also, the outborn newborns had quite a lot of mortality as well. So I think if we consider those things, then we definitely believe in the result. And can the results be applied to the local population? Yes. So if you think, when you take the rounds with Dr. Mohit sir, that in Nirmal also, if the population is same, less than 28 days neonates, and what we learn from this paper, we can definitely apply to the local population. Yeah.
Yes, sir.
And
Yes,
do
sir.
the results of the study fit with other available evidence? So that's what we what we ask Dr. Fagun sir, who know the Awaken study. So, Dr. Fagun sir, can you tell a little bit about the two studies comparison?
No, I think I mean I just went to the Awaken study long back, but as far as this Awaken study is concerned, I think there were around 600, 700 subjects, the neonates who had an AKI. The percentage of the AKI, I think so, was quite similar. It was also 30% of the children who are requiring AKI, but the number of the patients requiring renal replacement therapy was considerably lower. There only, I think, 24 neonates out of around 700 odd neonates required renal replacement therapy. So it was just around 4% of the patients. Even the mortality was very less. It was just 30%. And the renal replacement therapy which was applied in these patients was also totally different, because only 9 children were catered to a peritoneal dialysis. Otherwise, all else had the CRRT. And we don't know the type of the subjects also. As we in India, as you rightly pointed out, that the patients were outbound. They were mainly from the periphery, who might be very sick. We don't know about the characteristic of the patients over there. In fact, actually, I don't remember whether they were inbound, outbound patients, and what was the characteristics. So I think apart from these variables, other variables were quite similar as far as the other, which we say this outcome otherwise and variables were concerned.
Yeah. And the last one is, what are the implications of this study for your practice? So this is how the whole, I'll just show you what I learned from this study. I'll just show you. That's what your last slide was. It was, can it be applied locally? What I learned while critically appraising this study was that avoid fluid overload in newborn babies, identify sick neonates early, and stringent measurement of urine output is important. We Dr. Fagun mentioned very important thing is 25% of drug. I think when you calculate the dosage given to the neonates, one of the very important thing in NICU is the nephrotoxic drugs, and we should be very vigilant to see whether we should avoid the nephrotoxic drug. Normally, if you look at the developed countries, there is a 3-level checkup is there. Not a single doctor can write and give, and a nurse can give. There's a 3-level checkup in newborn babies to avoid nephrotoxicity by the drugs as well, because it is very easy to give at night rather than 0.01 amikacin to 0.1 amikacin, and it is a 10 times higher in small babies. So that's a very, very important thing as well. And keep vigilant watch on neonates with risk factors of AKI, and in sick children mortality is high for PD. So you have to always balance and risk while your child goes for peritoneal dialysis. So all this is how exactly critically you can appraise the paper and then take what can be the take-home points for your hospital as well. So that's how the journal club should be. So next time when we go for journal club, I think we will ask the participants to put all these things in a critical appraisal tool and with each presentation only. So it was the first time. So I think it is very, very important that we all learn this. Thank you very much.
Yeah, absolutely.
Over to Dr. Prashant, sir. Or Dr. Mohit, sir, you can take, or Dr. Somsekhar, sir.
Yeah. So this was a very nice discussion, I would say. And this was an add-on. And being me and Dr. Somsekhar being there, we would say, like, as we are handling the journal, if the sessions at the level of NNF, at level of students, it goes like this, it will be very useful for everyone. So this is quite a very healthy and nice discussion. And if the student presents in the similar way also, and some expert gives the how well Dr. Ravi expanded on that, that again will be a teaching point for all those people who have been attending these sessions. So even this kind of sessions, if they go the way it is today, it will be very helpful, because student, the one who is presenting, will be putting the papers as per his or her own thinking and expertise. An expert give his input like this will be very much very good learning points in crux. And on the other hand, the clinical parameter, the clinical points, we learned quite a bit from Dr. Fagun. So that's how, it complemented each other. So that's why, I don't know, personally, I like this session very well, very nice. And, I have been taken screenshots of this session. How well this session went off. It really went very well.
Very nice. So I just wanted to share, when we do Journal Clubs at our place, we have 5 statisticians who work under Central Research Services. We usually invite one or two of them for the Journal Club. So they come and also discuss on sample size, and they discuss on whether tests applied were correct or not. So that also helps us. So maybe next time, I thought if we are doing a Journal Club, we can try and invite one of. So I have 4 or 5 statisticians who are very good and who have published quite a bit. So we can probably invite them also as be part of the discussion. That might be also quite useful.
Yes, sir. Last time when we were doing all these sessions together, Journal Club every month, we used to do that. A statistician from your institute used to be there, and we used to have analysis of that. But sir, sometimes like the input from our fellows was, it meant, many of them, they were bouncers for, for our fellows and students. So that was their input. We didn't understand what this thing. So it has to be very much simplified, because this is what as a student we see. But that is really something which will be very helpful, because we used to do that, sir. Last year we did quite a few sessions like that.
Okay.
It will be great. Good. Yes, sir. Thank you.
Thank you. Over to Prashant.
So thank you so much to presenter Chandni for presenting in such a nice way, and also to both our experts, Dr. Fagun Shah, for taking all the clinical things, and Dr. Ravi Parekh for taking all the research things. So we enjoyed a lot, and I hope the students who have attended must have enjoyed this. Again, next Wednesday, Neonatal Pathshala at the same time will be there, and we will be having a PG case presentation on Down syndrome. So requesting everyone to register on ClearNet platform, as well as you can watch it on NNF Gujarat
YouTube channel. So subscribe to our YouTube channel also. Thank you so much. And thank you. We end the session over here.
Thank you.
Yeah.
Thank
Thank you very much.